So, good morning, friends. Welcome back to Saturday Club of Baroda meeting. And today we have very young orthopedic surgeon, Dr. Vasav Nakshiwala. Uh, Sorry, he's a consultant interventional radiologist to Vadodara. And his qualifications are MBBS, DNB in radio diagnosis, FIVR, and FINR. That are these fellowships that he has worked upon. Areas of expertise are neurointervention, peripheral vascular intervention, and image-guided percutaneous interventions. He was trained at Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, and he has more than 15 publications in peer-reviewed journals and books. And his current affiliation is irclinic Vadodara. So he is going to talk about basics of interventional radiology. So over to you, Dr. Nakshiwala. You have about 40 minutes to speak and we'll have 10 minutes of interaction. Thank you for joining us. Thank you.
Good morning, sir. Thank you so much for this virtual platform. Uh, and good morning, everyone, and good morning to all the senior colleagues and respected teachers. So I'll just introduce myself. I'm Dr. Vasav Nakshiwala, and this is my team, including Dr. Paresh, Dr. Jigar, and Dr. Rashesh. Uh, so I'll start with the just a basic introduction. What is intervention radiology? It's a minimally invasive therapy, or we can say it's a pinhole surgery. And beyond the diagnostic interpretation, we start interpreting the USG, CT scan, MRI, and SPET scan, and then do the procedure based on the diagnostic interpretation, which include the USG guided and CT guided interventions, the live X-ray called fluoroscopy guided intervention, as well as the modification of this technique called digital subtraction angiography. So these procedures are very minimally invasive. It has a shorter recovery time and it's very painless and very shorter post-operative period. So how it started? So there was a Swedish radiologist called Sven Ivar Sveldinger. So he invented this technique of vascular access, and from that all the intervention started. And after that, Dr. Charles Daughter, he was American radiologist who invented and first percutaneous transluminal angioplasty for severe femoral stenotic lesion. And this patient foot was saved from amputation due to a non-healing ulcer. So from then on, there are various applications from head to toe. Each of our body system has the application for intervention radiology, and each of these procedure will require a separate session. We'll just go through the different possible procedures option that we can provide with this uh, intervention radiology branch. So, intervention radiologist is basically a plumber. We block the vessel wherever there is a leakage, and we see open the blockage whenever there is a clot or a stenosis. So, just introducing the angiography, which is called a digital subtraction angiography, is advancement of the routine live X-ray, which we call a fluoroscopy. So here we can see the contrast injection into the vessels. And it's the DSS study is a very dynamic study which provides the arterial phase, parenchymal phase, venous phase, as well as the collateral formation. And here we can see there was this tiny aneurysm which was in the paraclinoid position and which was missed on the routine CT angiography. So it's very we can say that it's kind of a microscopic evaluation that we can establish with this digital subsection angiography technique. Now we'll go towards the procedures called the embolization procedure. So basically, these are the procedure which includes the blocking of the vessels. Okay, so we use various materials like PVA particles, these fiber coils, and glue, which is kind of a liquid agent to block the vessels. So we use these materials in various conditions. So we'll first start with the brain aneurysm, which for which the treatment is now shifting for the endovascular treatment. So here we can see that there is a large PCOM aneurysm and we have filled it with the coil under balloon assistance and excluded it from the circulation. For the wide neck and giant aneurysms, uh, we can do a stent assisted coiling, as well as there are newer device called a flow diverter, which diverts the flow away from the aneurysm. So, and also supports the neck of the aneurysm. Now, in the brain arteriovenous malformations, which present as a hemorrhage, seizure, and headache, we can see here as an abnormal tuft of these vessels, which is a very rare condition, but rarely it can bleed. And we go selectively with small catheters into the tuft of the vessels, and we inject glue or a newer material called squid, which provides the blockage of these tufts and spares the brain parenchyma. Similarly, into the spinal axis, this was a 6-year-old kid who presented with us with a paralysis, a loss of bladder and bowel control. And on the MR imaging, we could see the abnormal flow voids. And on the angiography, we could see the abnormal vessels, which showed a perimedullary arteriovenous fistulous connection. And in this patient, we selectively go into this vessel with our tiny catheters and we injected this glue. We can see the glue cast, which is white here on the CT scan images. And post procedure, there was a complete occlusion of this fistula. And we can see the 6 weeks follow up that this kid is dancing. Similarly, we are extending the spectrum of vascular malformation in the low flow malformation. We can do what we routinely do is percutaneous sclerosant injection under sonography and X-ray into these malformations, and we can see the cosmetic follow-up after 6 months. There is a significant improvement. Another application of embolization is a preoperative tumor embolization. So this was the younger adult who had a profuse nasal bleeding. Even with the touch of the endoscope, there was a profuse bleeding. So somehow he was managed with a nasal packing. On CT scan, here we can see there is a heterogeneously enhancing mass lesion, which is representing a JNA, which is called juvenile nasopharyngeal angiofibroma. So what we do is on the angiography, we can see there is a hypervascular blush and we blocked it with the small tiny particles called privae. This is the post-procedure picture. And after this embolization, the ENT surgeon could easily see easily manipulate as well as the dissect this tumor. He had the bloodless surgical field and less than 50 ml of blood loss. And also he could resect the entire tumor with complete visibility. So it aids with surgical resection also. Extending into the gastrointestinal system, we can see this patient had a upper GI bleeding and presented with the small tiny aneurysm arising from the gastroduodenal artery. So what we did was to we uh, selectively deployed a coil along the base of this aneurysm and protected the distal flow with natural collateral formation and blocked off the entire GD artery, which is a safer embolization. Transarterial chemoembolization is advancement of the embolization procedure in which we selectively go into this tumoral arterial supply and inject the chemotherapy agent as well as block this arterial supply. So here we can see this is the hyperenhancing tumor, and we have selectively gone into this arterial supply and blocked off with a PVA particle, as well as we have given a lipiodol plus doxorubicin. So it provides a selective chemotherapy. So it doesn't have any systemic side effects. So this is one of the example how this lesion involutes that this was the hyper-enhancing lesion pre-procedure, and after the procedure we can see the complete shrinkage and necrosis of this lesion. Similarly, in the large hepatic hemangiomas, when there are more than 7 centimeter in size and they are symptomatic, we can perform this transarterial embolization, which provides the shrinkage as well as the symptomatic relief, and we can avoid the hepatic resection in such cases. Portal vein embolization is a procedure in which when there are larger liver lesion and there is no sufficient functional liver remnant, we do ipsilateral portal vein embolization so that the contralateral hepatic liver lobe gets hypertrophied. Here we can see there was this was the smaller size of the left lobe. After the portal vein embolization, the left lobe gets enlarged, and after that the dissection was feasible for the surgeon. Bronchial artery embolization. This procedure is performed in moderate to massive hemoptysis when there is a more than the 300 ml of amount of blood is coming in the sputum, and or more than 100 ml bouts are coming 3 times per day. So here we see, here we selectively go into the bronchial arteries, and we can see this is the hypervascular blush, which is commonly seen in tuberculosis patient. And post embolization procedure, we can see the complete disappearance. So basically, this procedure helps to decrease the severity of the hemoptysis as well as the aspiration of the blood, which is sometimes life threatening. Rarely, a pulmonary AVM or AV fistulas are there, which may present as a hemothorax, recurrent strokes, or abscess. Here we can see this abnormal tuft of the vessels in the lung, which is abnormal connection between arteries and vein. So we selectively go into this artery, we deploy the coils, and we exclude this abnormal tuft from the routine circulation. Uh, This is the example in the kidney where large angiomyolipoma tumors sometimes present with hemorrhage and pain symptoms. And this is the post PCNL and post renal biopsy patient in which there was a bleeding. So in such patients, we go selectively into the branches, the selective cannulation of segmental arteries. We inject the glue and salvage the rest of the kidney, and as well as stop the bleeding. The varicocele embolization is a modern procedure in which we selectively go into the testicular vein from the left renal vein axis, and we block entire uh, gonadal axis with glue and sclerosant and coil as well. So basically, it is provide some edge to routine surgical procedures that surgical ligation may sometimes there is a recurrence after surgical ligation due to collateral venous supply. So this with this procedure, we make sure that there is no collateral venous drainage after the uh, uh, embolization procedure. The genicular artery embolization is also one of the advanced embolization technique in which in early or mild earlier grade osteoarthritis, when there is when this procedure can provide a significant pain relief. So we selectively go into the small genicular arteries which provide the supply to the inflamed synovium, and it sorts of decrease the inflammation as well as stops the progression of the osteoarthritis and provide the pain relief. But in advanced cases, this is not the treatment option. Uterine artery embolization, similarly, this is performed for postpartum hemorrhage as well as the large fibroids. When patient is symptomatic before of large fibroid, there is dysmenorrhea or infertility related issues. So we go selectively into this uterine arteries and block the fibroids with the small particles. Here we can see that this was the fibroid supply, and we block it with the particles, and we can see the reduction of the abnormal blush. And so, based on our experience, we have embolized this 10 centimeter, 15 centimeter fibroids with 6 months follow-up up to with shrinkage up to 2 to 3 centimeters. Uh, This procedure can also be used in the uterine AVM when they rarely present with massive bleeding after DNC or the post dilatation and curettage, and they form the abnormal arteriovenous connection. We selectively go into this abnormal tuft and blocked it with uh, glue kind of material, and it's a life-saving procedure. And another, similarly in the males, when there is a benign prostatic hyperplasia with large prostatic mass, more than 80 grams, the selective prostatic artery cannulation followed by embolization offers a gradual shrinkage as well as Foley's-free period for the patient, and also provides a effective surgical margin for the surgeon. Now, focusing on the recanalization technique, which includes the removal of the clots, which is called a thrombectomy and aspiration. So, starting with the brain, acute stroke, we all know the famous acronym BFAST, which is a loss of balance, loss of eyesight, facial deviation, arm and leg weakness, and speech difficulty. So, it's very crucial to know this brain attack. We are all aware with the heart attacks, but there is a very less awareness about the brain attacks. So, here also we have a very less time to act on. Initially there was a treatment called a thrombolysis, IV thrombolysis. Now we are offering a treatment called mechanical thrombectomy and thromboaspiration, in which we go transarterial with our catheter and with suction and with help of a stent retriever like device, we remove this clot. So here this was a young lad who presented early with us in 30 minutes window, and ICA was completely occluded. And here we can see in the bottom right corner, we have captured the clot in the stent retriever. And after the removal of this clot, we can see the continuous good flow across the MCA territory. So unfortunately, this video is not working, but this patient showed a on-table recovery immediately after removal of the clot. Similarly, this lady presented with a basilar thrombosis with a with a single pass of a thrombosuction. We opened the posterior circulation, and this lady recovered on the next day with she presented us with the weakness and aphasia, and she showed a complete recovery on the 2 to 3 day follow-up. So early presentation of the patient is very crucial in selecting this patient. Similarly, on the venous side, in the cerebral venous thrombosis patient, when they presented with a seizure or headache, we give the trial of 1 week of medical management and anticoagulation. Despite that, if there is a worsening of GCS, recurrent seizure episodes, and if there is no improvement, then we can offer this treatment of mechanical thromboaspiration, in which we go into the internal jugular vein, into the sigmoid sinus, and provide the suction along the suprasagittal sinus. Into the GI system. Similarly, in the case of acute abdominal angina, when there is a acute thrombosis of supramesenteric artery, classically it is seen in the procoagulation condition or a high-risk patient like smokers. The suction thrombectomy can be performed, and it can salvage patient from the mortality, morbidity, as well as the bowel resection. The length of the bowel resection can be reduced if patient is presented within time window period. Now, angioplasty and stenting. So, there are patients with recurrent transient ischemic attacks. When we investigate them further, they may present with the severe carotid bulb disease. So, nowadays, the carotid stenting is a very safe and effective treatment option compared to a carotid endarterectomy, because we have a newer devices called distal embolic protection devices now. So, this carotid stenting procedure has very less complication and less risk. I think less than 2 to 1%. And similarly, in the posterior circulation TIAs, vertebral stenting also is an option for prevents to prevent the future strokes. In the abdominal aortic aneurysm or dissection and a large stent graft placement is a treatment option where go from the femoral axis and we place the pajama graft in this large abdominal aortic aneurysm. Similarly, into this in this thoracic aneurysm, which was close to the subclavian artery, so we have placed the stent graft along the thoracic aorta, and this aneurysm was close to subclavian artery origin. So we have made a fenestration and scalloping which preserves the flow along the subclavian and also carotid vessel supply. The patient with in the patient with postprandial pain, which may have stenosis, severe stenosis, celiac artery origin, and SMA artery origin, the angioplasty and stenting is performed at their origin to relieve the symptoms. Similarly, the renal angioplasty, this is the patient whom has there was a renal artery stenosis after the renal transplant surgery. So, angioplasty and stenting was performed in the to relieve the symptoms. In the peripheral limb, regarding peripheral limb arterial supply, this patient had a left thigh claudication since 3 months, and with the left femoral axis, we have crossed this lesion and performed the angioplasty and stenting to relieve the claudication. This patient had the acute limb ischemia with uh, clot formation in the popliteal artery, for which we have performed the thrombosuction and aspiration to establish the good flow and sizable pain. And this was the another example where there was acute on chronic thrombosis. So initially we have done the suction thrombectomy followed by a stent placement for the unstable plaque, and we can see the improved circulation in the distal limb. The venous intervention spectrum uh, in the DVT and pulmonary embolism cases, the inferior vena cava filter is placed in long segment clots in common iliac veins and common femoral veins. And followed by that, we placed a small catheter into the femoral vein and from the popliteal vein axis. We used a special catheter called the pulse brake catheter, which inject the thrombolytic agents from the side holes. So along the entire thrombotic occlusion, there is a continuous infusion of this thrombolytic agent, and this is the pre-procedure picture, and after the recanalization, we can see the good flow across the occluded segment after the catheter-directed thrombolysis. Nowadays, there are newer treatment called angiojet thrombolysis as well, which are a bit costly. Uh, in the hemodialysis patient, when they often comes with the stenosis of the fistulas and thrombotic sites, and in this patient we should perform a transvenous access and fistuloplasty is performed to relieve the pressure symptoms. This patient had the central venous occlusion after the during the dialysis after the long-term dialysis fistula. So this was the occluded. Sorry for the network issue. Am I visible and audible now?
Uh, uh, yes, you.
So,
Can you hear me?
yes, sir, we can hear you. Hello.
I don't know about others. I am not able to see the slide.
So, sir.
Slide is seen and we can hear.
Okay, please go ahead. Vasu, please go ahead. It is at my
Okay,
end. Probably there is a problem with my connectivity. Please go
okay,
ahead.
sir. So, in the varicose vein, the traditional treatment that we offered was a venous stripping, but now we have advanced treatment like laser, endovenous laser treatment, in which we carefully evaluate the patient for a great saphenous vein and short saphenous vein reflux, as well as the perforator in the in the ultrasound, and we selectively access into the this great saphenous vein under sonography guidance, and we perform the laser ablation along the JSV and as well as the sclerotherapy for the perforators. But this patient requires spinal anesthesia and a tumescent anesthesia. So now there are newer treatment option called venous glue embolization, in which on OPD basis we can perform this glue injection along the dilated varicose vein, and from the same day onwards we can mobilize the patient. So this is the follow-up for the same patient. This was a pre-procedure dilatation of varicosities, and we can see the complete disappearance of this dilated varicosities after 6 months. In the the GI system, in the cirrhosis patient with portal hypertension, and if they have recurrent ascites and hematemesis, the transhepatic portal systemic shunt offers a good treatment option to relieve these symptoms. As well as in isolated gastric varices, we perform the balloon occluded retrograde transvenous obliteration, which is called BRTO. We go selectively into this dilated varices from the renal vein and inject the sclerosant within this abnormal channels to prevent the further oral bleeding episodes. In the Budd-Chiari syndrome, if a single hepatic vein is patent and occluded, the hepatic vein stenting is the first treatment option that can be offered. After that, if the all hepatic veins are occluded, the direct intrahepatic portosystemic shunt, which is called DIPS, offers symptomatic relief for the patient. Uh, Adrenal venous sampling, this procedure is done in the essential hypertension patient, where in the subset of the essential hypertension patient where we don't find the cause, and the patient had the aldosterone secreting nodules, which is not visible on the imaging as well. So we take the sample from both the left and right adrenal veins, and send them for the analysis for aldosterone level and cortisol level. So this patient had lateralization on the right side with increased aldosterone level. So that side adrenal was removed, and patient was symptom free after the procedure. Similarly, the inferior petrosal sinus sampling for the pituitary microadenoma. The fluoroscopic intervention, this is the common procedure that we all know, is percutaneous transhepatic biliary drainage for the obstructive jaundice to relieve the hyperbilirubinemia, as well as in the malignant patient to provide the option for the chemotherapy and further surgery. A catheter is placed via transhepatic route into the intestine to drain the bile, and also from the same access we can put a stent if surgery is not the option. Percutaneous nephrostomy and degestenting to relieve the urinary diversion and obstructive uropathy conditions. This is the advancement of the routine hysterosalpingogram, in which if the patient has the infertility related issue due to corneal spasm, we take our tiny catheters and wires and for a recanalization into the peritoneum, and we can see this contrast dye suggesting of the peritoneal spill. So this procedure called fallopian tube recanalization offer a solution for infertility. Similarly, a nasogastric tube placement under fluoroscopy guidance, a nasojejunal tube placement, and a PEG tube placement for the patients with advanced head and neck malignancy. This uh, tubes offer a feeding option for the patient. The intravascular foreign body removal, like broken lines and central lines and PICC lines, can be retrieved with a special device called snare under fluoroscopy. And this is the lymphangiography procedure, in which if sometime post-surgery, there is a rare presentation of chylous ascites or a chylous effusion, we inject the lipiodol into the inguinal lymph node. And sometimes we see the leakage from the lymphatic channel. So this procedure itself blocks the lymphatic leakage. The ablation procedures are the modern procedures in which there are newer advances like radiofrequency ablation, microwave ablation, cryoablation, in which to simplify that needle is targeting within the lesion, and with generation of the heat within this lesion or extreme cold within this lesion, we induce the necrosis. So this was the solitary metastatic liver lesion, in which we have inserted this RFA probe, and we can see the complete ablation of this lesion post procedure. And similarly, with with this hyper-enhancing HCC lesion, we have deployed this RFA probe, and this is the post-procedure. We can see complete non-enhancement, and we can avoid the hepatic resection. Similarly, same thing can be which are more on the cortical side. Uh, this is the RFA ablation for the solitary kidney lesion. For the benign symptomatic thyroid nodule, which often comes up with the cosmetic issues or pressure related symptoms, and radio frequency or microwave ablation uh, offers the shrinkage of this benign tumors. Biopsy drainage, we already know. Under CT guidance, we can target difficult location like retroperitoneum or a mediastinum, or uh, difficult bone axis like sacroiliac joints, the aortocaval and aortopulmonary lymph nodes. This is the example of a transjugular liver biopsy, in which the percutaneous biopsy was not possible due to an extensive ascites or a deranged coagulopathy. We take the jugular access, and from that we take the biopsy from the liver to assess the liver parenchymal disease, as well as measure the hepatic venous pressure gradient in the same sitting. Now, this is the routine extent. There is a newer technique called vacuum-assisted breast biopsy, which is the extension of the routine breast biopsy. In this, the biopsy probe itself provides the suction also of the tissue. So, smaller fibroadenoma can be sucked out with the single puncture, and it provides the treatment options for the patient who don't want to go surgery. And with the smaller puncture access, we can remove entire uh, small fibroadenoma tumors. This is the pigtail drainage commonly used for the abscess formation and pus collections in the body. So it's a very effective treatment in the liver abscesses, large liver abscesses. For 4 to 5 days, a pictal drainage offers a good assistance for with routine medical management and complete resolution. And pain management, the CT guided and ultrasound guided nerve blocks for nerve root and facet joints. And also, this is the example of the celiac plexus block to uh, provide a palliative pain relief, uh, is also a treatment option. So these are all the upcoming treatments in interventional radiology: the genicular artery embolization, prostatic artery embolization, the hemorrhoid embolization, the thyroid gland ablation and thyroid artery embolizations, and musculoskeletal embolization for pain relief. So we can conclude the sessions that these are the a single puncture procedure, very minimally invasive pinhole surgery with effective outcomes and shorter hospital stay. Thank you so much. And I apologize for the technical issue. Is there any question from the audience?
You can stop screen sharing, please. Okay. Dr. Sateshwari has some problem with connectivity. So if there are any questions, they are welcome. Dr. Vasav, you have almost approached every part of body except heart.
Yes, sir.
So I think, will you be considering angiography, carotid angiography, coronary angiography also in future?
No, sir. It's a very well established in the cardiology field, but the rest of the body parts also has a similar disease condition with treatment options which are available with the newer technical advances.
Okay. Are there any questions from audience? Hemant?
Question, since this is the epitome of the skills, because in 91 I had gone to Krishna Rao, there also visceral angiography and things were done, but today's generation have mastered the skill and actually delivered results for palliation and even cure. So this is a very high level skill, and we are very lucky that they have formed a team to deal with it. Because my only question is, there are complicated patients where there are bleeding disorders or patients who are on blood thinners. There the risk and the results might differ. No? When the patient is on blood thinners,
Yes, sir. When the patient is on the blood thinner and the deranged coagulopathy, first we assess them on the CT scan angiography, where if there is a focal bleeding point, then we can target that. But if there is a diffuse bleeding condition due to the deranged INR, then we don't have any option.
but you can do procedures on them, no?
Yes,
Other
sir.
procedures.
Yes, sir. Yes.
Just like intraoperative care, you need a hematologist to deal with the coagulation problems. Because we have had number of people who were refused in past. He has a bleeding disorder, so the visceral angiography would be difficult or dangerous. And in GI visceral angiography, there is a risk of whole organ falling off, necrose. If the problems, like you showed in pancreatic cancer, in duodenal angiography.
So in the GI embolization, when we perform the embolization, we go super selectively into the bleeding vessels, tiny bleeding vessels. And also there is a really good collateral support from the surrounding vessels to preserve the normal supply to the organ.
I know that, but especially in pancreatic cancer, when you try superior duodenal artery, but the whole main duodenal artery gets blocked, and we have
Yes,
seen,
yes. So rarely,
uh,
yes, we do see those complications. Yes.
but that we do in the patients who have no other way, and to palliate the pain of pancreatic cancer.
Yes, sir.
But a curative aspect of angiography and interventional radiology have grown a lot. And even in head and neck cancer for palliation, we have done, Paresh has done in one of the patient who was bleeding torrentially, and he could control and he could extend life for months of a doctor's father. So congratulations to your team and best wishes.
Thank you, sir.
Okay, sir.
Some of these cases are very critical. So your team is able to approach to the multi-speciality hospitals with facility to provide critical patients.
Yes, sir. We need at least a cath lab and the radiology facilities, the CT scans and MRIs available with the setup, so uh, we can reach the treatment.
So
Okay.
today, where do you practice all these complicated angiography
In the routine
intervention?
cath lab, sir. If the cath lab facilities are available, then in the cardiac cath lab only we can perform this routine vascular interventions. The brain, the neuro interventions will require some specialized the advanced cath lab features. Otherwise, in the routine cath lab, we can perform this procedures.
So your team is freelancing. You can go to any hospital and perform the procedure. That is the practice, no?
Yeah.
Yes, sir.
Okay. All the best. Okay. Thank you very much.
Thank you. Thank you, sir.
Yeah. If there are no questions, we conclude the session here. Thank you.
Thank you, Jagdish Bhai, for conducting the question answer session in my absence, because my connection has been very unstable. Sorry for some interruptions because of that. So we thank you, Dr. Vasav, for an excellent, very informative talk. And we look forward to more such talks from you in the future meetings. So thank you all
Thank
for
you, sir.
joining. We meet next Saturday morning again. Thank you all.
Thank you, sir.